Right, good morning, everybody. You're all very, very welcome to this morning as we continue with our medical course. I introduced Phil to you last week. Most of you know him from previous years anyway, but I'm delighted to introduce him. As you know, he went to school in both in Port Elizabeth and Johannesburg, and he specialized in medicine at Wits University, and then he studied further at the University of Toronto. He has worked as a specialist radiologist at Groote Schuur and Toronto University, as well as in New Zealand. He has lectured and published extensively in his field. So it's wonderful that we can have an expert like Phil in our midst to come and talk to us today. I don't know whether I should say I'm looking forward to it, Phil, because I think we're in for some gruesome pictures, aren't we? However, yeah, it is a fascinating topic, and thank you for coming to share your knowledge and insight with us. Thank you, Phil.
Thanks, Letitia. Thanks very much. I must say I'm very impressed with the people that are attending. I thought there might be less than 10 because, as Letitia has inferred, this isn't an easy subject. Most of us prefer to think that we don't have colons, and we certainly don't want to think about the contents. But the reality is that the colon is extremely important to our bodily functions, and it is sadly an important source of cancer in our advancing years. So let's have a look and see what I can tell you about it. Now we're going back to school as usual, and this is just an artist drawing of the colon. Drawings are always done as if you were looking at a patient from the front. So this side of the colon is on the right side of your body, and it has various portions. As you know, at the bottom there's the cecum, where the appendix attaches and where the small bowel enters at a valve here, a non-return valve, and then it's called chyme really, but the liquid feces comes into the ascending colon, goes up this way, across the transverse colon, down the descending colon, into the sigmoid colon. Now that officially is the extent of the colon. But for the purposes of this talk, we include the rectum. So the subject is really colorectal cancer rather than just colon cancer. Now, what does the colon do? You all know that it moves stool through the bowel. It gets excreted. And you might remember back to perhaps when you had kids or grandkids or little nieces, nephews on your lap, that when you fed them, immediately afterwards or during, they evacuated their bowels. And that's because there's a reflex called the gastric colic reflex, which largely gets lost in adult life. The other main function of the colon is to absorb water. And if we didn't have this function, we'd really be in trouble. We'd be sitting on the loo all day. Important as well is the absorption of minerals, particularly vitamin K and some of the vitamin Bs. There is said to be 100 trillion bacteria, fungi, protozoa, viruses, and archaea in the bowel. And this has taken on more significance in recent years. It's been called the forgotten organ or the microbiome. And these organisms together form a community of commensal, i.e. eat together, they eat with us, symbiotic and pathological microorganisms. There is said to be 100 billion bacteria per gram of stool. I'm not sure who counted that, but bacteria make up a significant volume of the stool, to the point that if you don't eat, you will still go to the loo, shedding bacteria. The one other thing I just want to mention, so important is this microbiome or forgotten organ, then that they're talking about a colon cranial pathway, you know, that there are, I don't really understand it myself. Other diseases can occur if the microbiome goes out of tilt, to the point that they now have fecal transplants. There's a thought for you. So if we look at cancer now, we can see that there's an exponential rise in the rate of cancer with advancing years. And we all know that, but perhaps we don't realize that, you know, the real significance. As we get older, we really have to be more careful about this condition. Now, at the bottom of the slide, in writing so small that none of us can read it, you will see that the incidence for men is of cancer of the colon 1 in 21 people, and women 1 in 23. There are a number of different types of cancer. The most common by far is skin cancer. But in men, the next one in line is prostate, then colorectal carcinoma, then lung, and women, breast, colorectal cancer, and lung. If we look at the symptoms, a lot of them are subtle. Bleeding may or may not be visible. So, and the bleeding that occurs with cancer of the colon is usually blood that's mixed in with the motion. So much as one doesn't want to, you actually have to have a look. Then the next thing is constipation. Obviously, if a cancer narrows a bowel, we will get constipated. And interestingly, chronic constipation can cause diarrhea. So they used to say that alternating or change in bowel habit, or they still say it is very important. Okay, so any change that you get, you know what's normal for you. If you get a change that goes on for a couple of months, you must have it seen to. One can get a feeling of incomplete emptying, thin stools, which is obvious if the bowel gets narrowed, abdominal discomfort, pain and distension, unexplained weight loss, fatigue, and then the real problem is that a lot of cancers don't have any symptoms at all. And certainly that's true of colon cancer, which is why we have to be cognizant of this problem and screen for it. We'll come to that later. So a number of famous people have had this. I've just put in a handful of them. You remember Ruth Bader Ginsburg, a Supreme Court judge in America. She, interestingly, had lung cancer, colon cancer, and pancreatic cancer. She had spread to her liver. And it turns out that lung, colon, and pancreas are associated with a single genetic abnormality called the KRAS gene. KRAS standing for Kirsten rat sarcoma, which is bizarre that we can have a rat sarcoma gene in us causing cancer, but it just reflects the fact of where the gene was first discovered. It was obviously discovered in rats, and it was discovered by Kirsten, so he got his name attached to it. And they're trying to classify the names of genes in a more logical fashion. So hopefully we won't have to deal with these funny names in the future. Now, another one was a cancer survivor was Ronald Reagan, and a further one, the Queen Mother. I heard stories that she had a colostomy from the age of 60 till I think she died at 105. But that wasn't true. She had her cancer resected, and the resection was repaired, so she didn't have a colostomy. The most recent Hollywood victim was this fellow, Chad, sorry, I can't see it, Boswick, I think his name is. And we may not be that familiar with him because he tended to do science fiction movies, which most of us wouldn't have gone to see. Now, when we talk about how cancer starts, I've done this with you before, but we have to go back to school again, and we have to go back to the cell. Cancer starts in a single cell, starts within the nucleus where the chromosomes exist. And you'll remember that humans have 23 chromosomes. The chromosomes are made up of enormous molecules of DNA. And the DNA is written in a language of only 4 letters. The letters are called nucleotides. There's guanine, cytosine, adenine, and thymine. And the structure of DNA requires that adenine can only link to thymine, and cytosine can only link to guanine. Now that becomes important when replication of the cell occurs. What happens is the DNA splits, unwinds, and I've just got a small segment of the DNA molecule here to show you how it works. There's the one side of it, and the other is formed in a mirror image so that cytine pairs with guanine and thymine pairs with adenine. But things can go wrong, as we've seen before. And here we have a guanine pairing with a thymine, which isn't allowed. So the cell has several mechanisms for repairing these mistakes, and it is able to go back to the normal configuration. But sometimes, as you know, mutations occur. And if you get enough mutations, you may get a cancer cell. Now, a cancer cell is one that has no restrictions on its growth or on the speed of growth. And so cancer cells become immortal, as it were. There's no stopping their growing, and we'll come to that again in a minute. So the other thing is that you can get born with mutations. You can get born with a genetic predisposition certainly for cancer of the colon. So we will end up with mutations in our genome, and we can get cancer. It is a genomic disease, as I've discussed with you many times. If we look at how things starts off as a little area of cells which hypertrophy, which grow abnormally. It'll start becoming a visible lump. And then the cells may change into a benign growth. There are many different kinds of growth in the colon. The most important one is called an adenoma, and it's important because it has the potential to turn malignant. And here depicted artistically are malignant cells. And malignancy usually starts at the apex of the adenoma. And at this point, a number of tests for cancer become positive in the stool. So we've got 2 here that look at DNA and their byproducts, and one that looks at blood in the stool, occult blood that you cannot see. And when we look at cancer from a medical perspective, it is staged, and it is staged according to how much invasion occurs through the wall. So we have the mucosa, the lining, then we have the submucosa, a small area rich in blood vessels and lymphatics, and that's situated between the mucosa and the muscle layer. And then we have the serosa or peritoneum here. So stage 0, there's no invasion. Stage 1, the cancer goes through the mucosa and the submucosa. Stage 2, it's through the muscle. And stage 3 now, it's gone through the serosa and can start to invade lymphatics. Although if lymph nodes are involved, they're regional lymph nodes, not lymph nodes far away from the tumor in other parts of the body. And then stage 4 has taken it to the ultimate step where cells have gone either into the lymphatics and or into the blood vessels. Now, you'll remember from a previous talk I gave you that these cancer cells are able to enter a blood vessel, and they do this under genetic control, and they're able to leave the blood vessel also under genetic control. This could be a cancer cell entering liver. It finds itself in a really hostile territory. So there are genes that allow it to set up house in the liver, and there are genes that allow it to recruit new blood vessels that it needs to grow rapidly. So I thought we'd just look at a bit of anatomy here of the blood vessels. And there's a big one. The Americans used to call this one at the back, they used to call it Big Blue. And Big Blue is the inferior vena cava. And the renal veins enter the inferior vena cava, and so do the iliac veins from either leg. And you'll see the lower third of the rectum also enters the iliac vein. But the point is that most of the blood of the colon is drained by these vessels here, going up to join the portal vein. So why is that significant? Because the portal vein drains into the liver. The portal vein is actually the main blood supply to the liver. It's one of the few organs, if not the only organ in the body, which has a main blood supply from a vein, not an artery. But what we're talking about, so we've got invasive liver cancer going into a blood vessel, going up, in this case, in the inferior mesenteric vein, into the portal vein and into the liver. So what happens is we get pieces of liver growing, pieces of colon growing in the liver. So here's a CT scan. These are ribs here. This is the spleen. This is the stomach. There's a vertebral body with the vertebral canal where your cord is. Here's the aorta, the main artery in the tummy. And here is the liver. And the liver has these low density spots in it called metastases or secondary deposits. And that's a radiograph, and here's what it looks like in real life. And these metastatic deposits grow without restriction to the point that eventually they take over the function of the liver, and the liver will fail. They can also spread from the liver. There's a draining vein from the liver which goes via the heart to the lungs. So they will then spread to other parts of the body as well. Now, the other thing I mentioned was lymph nodes, the lymphatics. The lymphatics follow the arteries. So these aren't portal veins. This is the superior mesenteric artery, inferior mesenteric artery. And along the arteries are the lymphatics. And again, tumors can enter the lymphatics, and they usually end up not in the liver, because these lymphatics don't drain to the liver. They drain higher up, usually to the lungs. So if we look at the percentages of cancer in various parts of the colon, you'll see that most cancer occurs on the left side of the colon, 50% on the left, and that's in the descending and sigmoid colons, as well as in the rectum. That has clinical significance in that in some countries they examine, if they're doing a screening test, they only examine this side of the colon. But I would advise you, when you have your screening test, to have the entire colon looked at. We will come to that. So cancer of the colon has a 25% chance of having a family history. Most of the cases are sporadic, i.e., as I showed you, mutations occur, mutations accumulate in somebody who has no history of colorectal cancer. There are a couple of bad syndromes, which I'll just show you quickly, which are inherited genomic aberrations. We saw Ruth Bader Ginsburg, she had one, the KRAS. And the next two I'm going to show you are autosomal dominant, and you'll remember how that inheritance works. Here's somebody who has colorectal cancer, and 2 of her 4 children will carry the gene. That's what happens in dominant inheritance. And recessive, which we're not talking about today, would have 1 in 4. Two would be carriers, 1 would have the disease, and 1 would be normal. So there are these 2 conditions. The one is called Lynch syndrome, and it carries a higher risk of cancer of colon, stomach, small intestine, endometrium, ovary, hepatobiliary, pancreas, brain, prostate, breast, and skin. So some people have all the luck. And the other one is familial polyposis. This can occur at a very young age. These people get hundreds of polyps. There are 3 genes that are implicated. All of them are dominant. And it is mostly a sporadic condition. There's a 100% chance of cancer. And commonly they will do a prophylactic total colectomy and take out the entire colon, because they know there's a 100% chance that it's going to go malignant. They also have an increased chance of pancreatic, liver, and thyroid cancers. So if we look at a resected bit of colon, this is the normal lining or mucosa of the bowel. This, you can see the bowel has been laid open. They call it filleting. And in the middle here is a single polyp. That is an adenomatous polyp that we were talking about before. And if you have familial polyposis with a 100% chance of cancer, this is what their mucosa looks like. Every single little bump here is an adenomatous polyp. So you can see why the chances of malignancy are so high. There are, sorry, I just have to move this out of it. Non-modifiable risk factors for cancer, and there are modifiable risk factors, which we've talked about in, a couple of years ago, I think. So non-modifiable ones, first is obviously age, where 90% of colorectal cancer are in individuals over 50. If you have a history of ulcerative colitis, that's an inflammatory condition of the bowel with an increased risk. And you might have the family history. Remember, we talked about 25% having a first-degree relative with cancer of the colon. And then we talked about those 2 genetic disorders, the Lynch syndrome and the familial polyposis. And if you have a history of previous adenomas, previous polyps, that is a risk factor for more of them. And then the modifiable risk factors are alcohol, smoking, obesity, diabetes, consumption of red meat, South Africans love that, and processed meat, salamis, ham, etc. What tests can we do? Well, there are tests on the stool. They look for occult blood, blood that we can't see. And these tests generally look for the heme part of the hemoglobin. And then there's fecal immunochemical tests, shortened to FIT, and these look for the globulin part of the hemoglobin molecule. There is stool DNA, so as the polyp or cancer sheds its cells into the feces, so DNA from the cell can be detected. Then there are radiological tests. One here I'll tell you about, the barium enema, and nowadays they do a double contrast, which I'll show you. Sigmoidoscopy, which that's a little tube which they put inside, the surgeon puts inside you and looks at the left side of the colon, because that's where most cancers occur. But we looked at the entire colon with colonoscopy. And there's a radiological way of doing this, a sophisticated CT scan, which creates a virtual colonoscopy, and that's called colonography. I just put these radiological tests at the bottom to say that cancer can be found sometimes incidentally on ultrasound or CT or MR, but this is not the main way radiologists use for detecting cancer. So this is a double contrast barium enema. The barium is this white stuff here, up here. Here is a loop of bowel. And the barium has been used to coat the mucosa, coat the lining of the bowel so that it stands out. You can see it here. Otherwise, you wouldn't see it unless it was coated. And as we go along, and then air is put in. So that's what this blackness is. So we have a coated bowel containing air, and that's a double contrast barium enema. As we come along this loop here, you can see suddenly there's a narrowed portion of the bowel, which is very irregular. And radiologists normally use, and doctors in general, normally use food as the visual cue for what they're looking at. And this is called an apple core. You can imagine that. That looks just like an apple core. An apple core narrowing of the colon. An apple core lesion is classical of cancer. And here, the next image is a single contrast barium enema where only barium has been put inside. And I'm sure all of you can now see this narrowing. Here is yet another apple core lesion. But I wonder if any of you spotted a second one here. So there are two cancers in this one loop of bowel. And it becomes very important when surgeons or gastroenterologists examine your bowel that they examine it entirely so that the second cancer is not missed. So if you go for a colonoscopy, this is what you can expect. 24 hours before the test, you have to clear out the bowel with laxatives, and you spend quite an unpleasant day on the loop. I can't say it's pleasant. I had that done a few months ago. Then in the surgeon's room, they lie you on your left-hand side. The good thing about it is you get administered an IV drip. And from then on, certainly here with the chap I went to, I was unconscious. So I knew absolutely nothing about what happened next. The colonoscope is inserted and the surgeon or gastroenterologist tries to get it all the way around to the cecum. It's not an easy thing to do for them, but they're experienced. And this again, another view to show you a colonoscope going all the way around. This is the steering wheel down here. It has, if you look at it, it has light sources. This is an end viewing scope. There are scopes that view to the side, but in the colonoscopy, sorry, they use an end viewing scope. And there is a channel with a camera, so they can look on a TV screen exactly where they're going. And there's a channel for putting instruments in, so that they can put a little tube in with a snare, and they can grab hold of a polyp, which this fellow here is going to show you now.
You're watching a colonoscope being withdrawn from a healthy colon, and a bump is noted at the very bottom of the screen, which represents a polyp. To remove the polyp, a white catheter is extended from the scope, and from the catheter a loop of wire, which is tightened around the base of the polyp to allow electric current to be placed through the wire to both cut and cauterize the polyp off of the surface of the colon. The scope is then advanced, and suction is applied to retrieve the polyp and send it to pathology for evaluation. The underlying tissue is then further evaluated to make sure that no residual polyp tissue is left behind. As the scope is withdrawn, the divot that is left from the polyp is again looked at, and this will heal completely without any evidence that the polyp ever existed in the first place. The purple little extensions, which represent a rubber cuff, allows retraction and visualization of the underlying colon.
Now, just to talk about adenomas, I mentioned this is a type of polyp, the significant one that grows in us, and 20 to 40% of colonoscopes will reveal an adenomatous polyp. And this percentage will increase as we get older. And 30 to 35% of patients with an adenoma will have more than one in 3 to 5 years. That's why if you have one, you need to get checked again. And 80% of cancers of the colon arise in an adenomatous polyp. This is what a pedunculated polyp looks like. These are the ones the surgeons really try to find because they're easy to put that little snare around. And then this is a different kind of adenomatous polyp. It's a flat polyp here. You can see it, well, you can hardly see it, but it's there. And what's happened in this image is that a dye has been injected at this point here, a small injection of stuff called methylene blue. And then they wait for a couple of minutes and the dye diffuses into the tissues of the tumor, and from there into the lymphatics. These are lymphatic channels, and they're even filling distant to the polyp with the dye. You can see from this image how a tumor can spread easily into the lymphatics and affect your regional or distal lymph nodes. If we fillet a piece of colon with a cancer in it, this is what you may see. This is a typical, they call it a malignant ulcer. So the cancer produces these thickened rolled edges with a depressed middle, and that needs to be resected. And if you were having a colonoscope, this is what that same cancer would look like. So now we're going to go on to radiological examination of the colon, and this is now a specialized CT scan where this image shows a three-dimensional view of the colon. All the other tissues, the bones, the spleen, the liver, the aorta, whatever you like, have been subtracted out very cleverly. And we are left with the colon alone. you'll see a little projection coming off the colon here. That's a diverticulum. So some of you may be aware that you have diverticulosis. These things can get infected and cause trouble. And in this image, the radiologist has just traced the course of the colon through these tortuous loops. You can see where a colonoscope would go, how it would work. But I have another little movie for you. And this is now a virtual colonoscopy. It's called colonography. This is a series of images that I'm going to show you, which are created by high definition, three-dimensional CT scanners. The scanner here in Hermanus is not one of these scanners, unfortunately. You'd have to go to Somerset West or Cape Town to have this examination done. Now you're looking into the bowel. This pink stuff is bowel. This here is a tube through which, sorry, let's go back one step. You have had to have the bowel prep the day before, just like for a colonoscopy. So the bowel is cleaned, and then carbon dioxide is pumped into the bowel to distend it. You don't need sedation for this test. You don't need to be asleep, and you can go to work straight afterwards. So let's see what happens. Star, I want you to sit there now and fasten your seat belt, and off we go. We're now, this is called a fly-through journey through the colon. And right at the end, in the cecum, here is the problem. This is a tumor projecting through from the small intestine into the cecum. Sorry, that was a bit quick. If you want to see that, have that journey again later, we can do it. It should last a few minutes, but it doesn't matter. So looking at various images, virtual images that radiologists can produce, this is that view of the colon, only the colon, everything else subtracted out. You can see there's a narrowed portion of the colon here. And in that narrowed portion is a polyp. There's the polyp, and this is the filleted view showing the polyp. So one can tell the surgeon that there is a polyp in the sigmoid colon at 25 centimeters depth from the anal margin. You can tell him exactly where it is. So colonography, image-wise, is just as good as colonoscopy, if not better. The downside is that polyps cannot be removed with colonography. If a polyp was found with this method of detection, you would still have to go for a colonoscopy to have your polyp removed. This is what the future may hold, just swallowing a little pill in a clean bowel, and the pill would have a couple of cameras there. If things are left too late, then surgery is needed. This image showing a section of the descending colon, which has been removed and then cobbled up afterwards. If one is lucky, that can be done at the same sitting. Otherwise, you have to have a colostomy, where the end of the colon here is brought up to the skin, and a bag has to be put on to catch the contents of the bowel. A colostomy also occurs, also has to be put in tumors which are very low. So low rectal tumors cannot be resected fully, and or not anastomosed, should I say, not joined on. They can be resected, but they can't have a junction after resection. So a colostomy bag has to be fitted. And in real life, this is what a colostomy bag looks like. And some of you may well have had this. So the other thing that happens nowadays is laparoscopic surgery. So instead of making a big cut from the top to the bottom of our tummies, pieces of colon can be resected through small tubes. Not easy, but they resect the colon, mulch it up, put it in a plastic bag, and then extract it through these small tubes. And then they are doing similar techniques to prostatectomies now. That is, removing prostate. They are using potentially robotic surgery, where the surgeon would sit at a console and he would orchestrate these small probes going into the abdomen. Now, how often are we going to look at you, screen you? Everybody at 50 should have a colonoscopy or colonography. And this is usually comes up after dinner. If you come to dinner at my house, after the meal, I tell you, I start talking about this. I'm passionate, I must say, about people having colonoscopies, because I feel that cancer of the colon is preventable. Nobody should get it. All you need to do is hide your embarrassment for a day, for an afternoon, and go and have a colonoscopy. So it should be done every 8 to 10 years after 50. If there's a history of colorectal cancer, the first examination should be done 10 years before the relative's presentation. So if Uncle Jack had cancer of the colon aged 50, then you should have your first examination not at 50, but at 40. If a polyp's been found unexcised in a previous examination, then it gets done again every 3 years. If a previous cancer has been found, then annual examinations are required. And if there's a genetic predisposition, also annual examination. In conclusion, cancer of the colon is a common cancer. It seems to be presenting in younger and younger people. And sadly, I have 2 colleagues who lost children to this disease in their late 20s. Late 20s. They were both, one was 28, one was 29 years old, cancer of the colon. It is commonly asymptomatic until it's advanced. And that's why we have to look for it. It is curable if it's detected early. So colonoscopy or colonography is recommended from 50 years of age. This is to remind you, this to clean your letters properly. This slide you might call light at the end of a tunnel. In somebody who was having a scope, they found a ladybird climbing towards the scope. And that's all we're going to do. I'm going to say thank you for listening, and go and get your colonoscopy, please.
That was gruesome, but very, very interesting, Phil. Thank you very, very much.
We can't help not being gruesome for these things, but it's so important.
Very fascinating, very important. Thank you. I'm sure Phil is happy to answer questions.
You mentioned the flora in the colon, in the gut. I've often wondered how these bacteria and microorganisms survive the terrible acids in the stomach and how they actually get there without dying.
Yeah, gee, that is interesting. You know, okay, the acids are only in the stomach, right? The pH changes on the journey through the bowel, from mouth to esophagus to stomach to intestines. So the pH of the mouth and esophagus is alkaline. The pH of the stomach is very acid. The pH of the intestines changes again to alkaline, and the pH of the colon becomes acid. Now, some bacteria love acid environments and some love alkaline. And those bacteria I spoke about, called archaea, are are bacteria that live, but they're not actually bacteria. They're their own group of organisms. They live in hostile environments. They also, some of these bugs are anaerobic, they call them. They don't need oxygen to exist. So although the environment would be hostile for us, these little guys love it.
I've heard people advocating you should detoxify your system and actually clean your bowel every so often. What do you say about that?
I say if you want to do that, that's fine. That's fine. I know a lot of spas do that. There's that one in Stellenbosch, which I forgot its name. They do bowel washouts. I don't think it's harmful. I think it can do a lot of good. I know people who've really benefited from that. Talking about washing out, when we take antibiotics, say you've got a pneumonia like you had, and they give you oral antibiotics. Those antibiotics can do huge damage to your bacterial flora in the gut, and that's why nowadays they give you I can't remember what it's called, but yogurt type preparations to recolonize your bowel. So I would have nothing against colonic washouts, absolutely not. Might help you.
And would you recommend just taking fluids, or do you recommend an enema for that?
I don't know. I can't answer that. Maybe I don't know if Patrick's there. I don't think that would matter. They work on in different ways. I mean, the preparation you have prior to colonoscopy is a thorough clean out. Let me tell you, you spend a few hours on the loo cleaning your bowel, and whereas an enema may not be, it's probably a bit more gentle than the certainly the colonoscopy preparation. Other laxatives don't have to be as harsh as the colonoscopy prep. I don't know which.
Diana, may I ask your opinion on using probiotic natural things like kombucha and kefir or kefir, depending which way you pronounce it, on a regular basis?
I think those things are good. Sorry, probiotic was the word I was looking for with if you have antibiotics. Nowadays they give you an antibiotic and a probiotic. Yeah. Anything that reestablishes the normal flora of your intestine can only be good. And this is why in the beginning I chatted about, losing your normal flora and this, not a tendency, but this possibility of having a fecal transplant to reestablish the flora in your bowel. It's not something I can get my mind around really, but doctors are doing it to great benefit of people who need it.
Because my husband's family has a history on his mother's side of cancer of the colon. He's had polyps removed, he's had diverticuli, and that actually got so bad that there were adhesions in the sigmoid colon and it was removed. And we've used kombucha and kefir probably for 5 or 7 years now. And interestingly enough, when he went for his checkup colonoscopy 5 years after the sigmoidectomy, diverticuli had already started developing further up.
Yeah, okay. Diverticuli and polyps are different, right?
Yeah.
So we don't, and diverticuli are not pre-malignant. They're annoying for sure. If they get inflamed, you're going to know about it. You're going to need antibiotics. They can get chronic inflammation. You can go on to have a narrowed segment of the colon, as your husband did, and occasionally they may need resecting. I thought, Diana, the important thing for me about your husband's story was the polyps and the fact they weren't malignant, or they were?
No, they weren't. And he started going for colonoscopies when he was in his 40s, and they were discovered, and the original one was too small, and he had to go back, I think it was a few months or a year later. 18 months, he says, and the surgeon snared it, and it was sent for biopsy, and it was fine.
It was fine. It's just raising perhaps a little red flag that your children must be careful and have scopes as well. They mustn't get out of that.
Yes, no, we have told them. Interestingly enough, the younger one is pretty pedantic, and I think he was probably in his late 20s and spoke to the GP about going for a colonoscopy for a checkup, and he said, well, he thought that was a little bit young. But yeah, no, they will start in their 40s, definitely.
You know, if they're young, I mean, those two doctors' children I told you about, you know, both of them presented with bleeding. Both of them went to their GP. Both of them were told, oh, don't worry, you're young, you've got piles. And both of them were not, look, cancer in young people is often a terrible, aggressive disease, and it may not have helped to have had a colonoscopy at that stage. But the fact was, because they were young, they were dismissed, which is dangerous because we can see that the age of onset is diminishing. So that's scary, isn't it?
There's a question from Rod. Rod, go ahead.
I was actually asking also, one of you asked about, were diverticular, were they in any way indicative of cancer to come? And should one have more frequent colonoscopies if a previous colonoscopy has indicated a diverticular, one or more?
No, they're not related, Rod. That image I showed you with diverticuli on the one side and I think there might have been a cancer on the other, they're not related. Diverticuli are sort of little hernias of the mucosa, the lining of the bowel, the internal lining, through the muscle layer of the bowel to the outside. They're this little balloon which forms, and stool can get trapped in these little balloons and they can get inflamed. But although chronic inflammation has been associated with cancer, as far as I know, they are not a cause of cancer. If I had diverticuli, I think, well, they told me on my scope that I did, but I'm not worried about malignancy. I'm worried about polyps.
Phil, yes, sorry, Rod, are you done?
So, Phil, yes. Diverticuli as of themselves can also be dangerous, can they not? I have a feeling.
Yes, they can.
My knowledge have died at first diverticuli.
Yes, they can. They can become inflamed, and if you're unlucky, they can perforate. So once they perforate, that allows fecal matter to go into the peritoneal cavity. Then you've got peritonitis and you're in trouble. You're going to get an abscess, and you can land up with a colostomy and all sorts of drama. So when one gets diverticulitis, then normally that's treated quite vigorously with antibiotics. It may need hospitalization. And really it has to settle because you don't want a perforation.
So here's a question from Lydia. If one has been diagnosed with IBS, can this lead to colon cancer?
There are various forms of inflammatory bowel disease. And the one you have to worry about is ulcerative colitis. ulcerative colitis is an inflammatory disease of the colon. If you have it for 10 years, you have a very increased risk of cancer of the colon. Other forms you may have heard about are Crohn's disease. And as far as I know, that is not pre-malignant. It's a miserable condition to have. And then you may get from your GP, your gastroenterologist, a diagnosis of IBS, irritable bowel syndrome. And this is an obscure condition to me. It's people who have discomfort, cramps, bloating, just a miserable sort of existence with their colon, but it's not in itself pre-malignant. The one, just the one you have to worry about is ulcerative colitis.
Phil, if the whole colon is removed due to cancer, how does the body cope without that organ?
From the function point of view, you would need, from the vitamin point of view, you would need to take supplementary vitamins, supplementary vitamin K, supplementary B vitamins. You are stuck with a situation where the fecal matter is very watery. And if they join you up, if they take out the entire colon and join the small intestine to the rectum, you are going to spend most of your life on the loo. So there are two alternatives to that. One is to have a bag, which is called an ileostomy, where the fecal contents go into the bag. But there is you don't have control over that. The bowel empties when the bowel empties, and it's not an easy thing to live with. An ileostomy is much more difficult to live with than a colostomy. The colostomy at least has formed stool going into the bag. The ileostomy has this watery stuff. And then finally, what they try and do nowadays is to create another rectum for you. They reconstruct. There are colorectal surgeons. There are a few good ones at Kingsbury Hospital in Cape Town. And they use loops of small bowel. They sort of form an S shape, and they open the wall in between two loops of bowel. So I don't know if you can see that. So there's a loop of bowel and another loop of bowel, and I sew them together, but I take away the adjoining wall in between. And I do that with a number of loops, and they form a pouch called a Parkes pouch, where the liquid stool can undergo water resorption and where there is more control of evacuation for these patients. But you're right, it can be very difficult.
Any other questions?
This has been absolutely fascinating. Thank you, Phil, and you've answered people's questions with such understanding and insight. We are really blessed to be able to call on you. Thank you very, very much.
And thank you to all of you for being so brave to listen to.